A pleural effusion is fluid where fluid shouldn't be, between the chest wall and the lung parenchyma. Now, there's a little space where fluid is to allow the lung to move, but you put too much fluid in there and you get a pleural effusion. The very first thing you have to do with a pleural effusion is separate it into one of two forms. And we can talk about the pathogenesis of a pleural effusion. The two forms are transudate and exudate. In general, if you have to pick one, transudate is the one you want. Transudate is caused by fluid falling out of the capillary space. The vessels are tight, but some other force causes the fluid to leak out. That's either hydrostatic pressure in the way of congestive heart failure, or it's loss of oncotic pressure. You're going to see the pleural effusion as part of anasarca. You'll see that in nephrosis, gastrosis, and cirrhosis. The OSI. Nephrotic syndrome, kwashiorkor or protein malnutrition, or a protein-losing enteropathy, and cirrhosis. These are oncotic forces. Exudate, on the other hand, means that there's stuff in the space. That is, the capillaries have opened up sufficiently so that proteins were able to leak out. That's caused by inflammation. So what you want to think of on the exudative side is going to be malignancy, pneumonia, and TB. Knowing that TB is probably the most common cause of pleural effusions worldwide, whereas in the United States, pneumonia, malignancy, and CHF are the most common. Now, you're going to expect to see a pleural effusion generally in the same patient you expect to see CHF in. It's going to be the person who gets dyspneic when they lay down. They've got orthopnea, they have dyspnea on exertion, and they're going to have dullness or percussion at the area of the effusion with decreased lung sounds. You're not really going to miss the clinical picture of a pleural effusion. But when you are trying to diagnose a pleural effusion and you don't know one's there, the chest x-ray is not a bad place to start. And you might do this anyway because they present with shortness of breath. This is a lung, this is a lung, this is the diaphragm. When pleural effusions are very small, you may not notice them. Normally, there's the lung and the diaphragm, and the costophrenic angle is clearly visible on chest x-ray. As you get that small effusion, you'll have blunting of the costophrenic angle. But that's not specific because a lot of things can do that. You don't know if that's atelectasis or consolidation. But as the effusion gets bigger, it becomes more clear. What you'll see is a horizontal meniscus and blunting of the costophrenic angle. That, you know, is fluid in the chest. Fluid where fluid shouldn't be. But you don't know if this is a hemothorax, a chylothorax, or just a pleural effusion. Blood, chyme, or fluid. The way you figure that out is by actually getting into the chest. You do a thoracentesis, you put a needle in it. But a lot of what you're going to have to do, both in life and on the test, is decide, who can I tap? So someone comes in with the signs and symptoms of pleural effusion. What do you diagnose one on chest x-ray? The first thing you're going to do is get some imaging. Now this used to be very clearly an x-ray. But I'm calling it imaging now because there are different modalities you can use. And there are three. The modalities you can use are going to be a lateral decubitus x-ray, ultrasound, or CT scan. If you have to pick from this list, choose lateral decubitus x-ray film because it's the cheapest. What you're doing with each of these tests is trying to figure out if this fluid is loculated or not. Is it a simple pleural effusion that you can go into with a needle, or is it complicated and you need a surgeon? A couple things can come out of this imaging. It doesn't matter which one you pick, but the lateral decubitus will be right on the test. If it's really small, the layering out is only about 1 centimeter or less. This is too small, and you're simply going to watch and wait. Especially in the case of congestive heart failure or cardiothoracic surgery. If, on the other hand, you get septations, little lobes of fluid, pockets of fluid, this is loculated. And loculated effusions need to be a little more aggressive. What you're going to start off with is a thoracostomy. This is a chest tube. And what you can do, and this is going a little beyond the MS3 level, is use TPA through that chest tube. The idea is you put the tube in so stuff drains. You can speed up the drain by using TPA. There's a little more nuances in here, but what I want to show you is that if the chest tube fails, you have to do something extra. If the thoracostomy fails, you need to do a thoracotomy. That is, crack the chest and get in there and do some surgery. This is for debridement. But even if it's big enough to be tapped and it's not loculated, it's none of the exclusion criteria, you still do not tap. If the person has CHF, regardless of how big it is, regardless of which side it is, unilateral, bilateral, whatever, if you've got a pleural effusion and they have CHF, the chances that it's caused by CHF is so high that you should just diurese and see what happens. And if they do not have CHF or the diuresis fails, that is your chance to do the thoracentesis. And in it, you're going to get a lot of information. The thing that comes up on wards and boards all the time is this a transudate or is this an exudate? And you separate that with Light's criteria, worth committing to memory. There are 3 things you test with Light's criteria. It is going to be the LDH of the fluid, the ratio of the LDH of the fluid to the LDH of the serum, and the total protein of the fluid compared to the total protein of the serum. Now, you're talking about a pleural effusion, so fluid comes first. Fluid comes first in the ratios. If you're talking about a pleural effusion, fluid comes first. What you're trying to decide is there stuff in the pleural space, or is it just a bunch of fluid? You can imagine if you've got leaky capillaries from inflammation and it's an exudate, stuff's going to leak out into the pleural space. If you have a lot of stuff in the pleural space, the numerator goes up, the ratio goes closer to 1. If, on the other hand, you don't have that, it's just a bunch of fluid floating around in the pleural space, LDH and total protein, the numerators go down and it's closer to 0. I'll say it again. It's because it's an effusion, fluid comes first. It's an exudate when the numerator goes up. What you have to commit to memory are these numbers. LDH of the fluid greater than 2/3 the upper limit of normal. The ratio of the LDH in the fluid to the LDH in the serum is greater than 0.6. Total protein of the fluid to total protein of the serum is greater than 0.5. You need any one of these are or statements, to be an exudate. You need all of them to be negative to be a transudate. Any one Light's criteria, exudate, all Light's criteria, negative, transudate. But you're going to do more than just figure out if this is a transudate or an exudate. Right? You put a needle into someone's chest, you really want to know what the hell's going on in there. So what you're going to do, and this is more for life than it is for the actual test, what you're going to do is send for studies. And you're going to send 4 tubes. Tube number 1 is the cell count with diff. Tube number 2, cytology. Tube number 3 is the fun stuff. Let's hang on to that one. And tube number 4 is actually a blood culture bottle that you inoculate at the bedside. What you're sending for is gram staining culture. And of course, you're looking for bacteria, fungi, and TB. And you can start off with the AFB smear, fungal smear, bacterial, gram stain, and then you wait for the culture to grow. The cell count with diff can give you a number of information. What you're looking for is a pneumonia, and that is going to be primarily a leukocytosis with polys, TB, or malignancy, which will be white cells with lymphocytes, or you're looking for red blood cells. That's either going to be a hemothorax or cancer if you have lots of reds. Cytology, of course, is going to mean cancer. And if you have a cancer that is in a pleural effusion, it is immediately stage 4. Malignant pleural effusion means metastatic disease. And the fun stuff in tube number 3. This is the stuff I don't want you to commit to memory, but I want you to hear about it so that you know about it when it comes up. Things like the glucose and the pH aren't useless. They're just not pathognomonic. They can be useful for differentiating complicated pleural effusions. Of course, you're going to send off for the total protein and the LDH to do your Leitz criteria. But some things you should remember are going to be things like the ADA, the adenosine deaminase. This is for TB. We talked about lymphocytosis and an AFB smear, but the ADA is the best test to do on the thoracentesis. And then triglycerides for a chylothorax. All right, this is more for life than it is for the test. This is more for the test. Recognize the pleural effusion on the chest x-ray, and then know when to tap and when not to tap. You do not tap if it's too small, it's loculated, or they have CHF. You do tap when it's big enough, free-flowing, non-loculated, and either diuresis didn't work or they don't have CHF. You use the Leitz criteria to separate into transient and exudate. And one more time, if it's loculated, chest tube first, surgery if it fails. That's pleural effusion.